Yeah, that's right. So really well done. So the presentation again, I'm going to just do the quick presentation. This is a plain CT head axial cut showing right-sided biconvex hyperdense lesion that is most likely extradural hematoma, and this is causing mass represented by effacement of the sulci, midline shift, and compression on the ventricles. What are the advantages and disadvantages of doing a whole body CT scan in this scenario?
So it provides us with an early diagnosis for any other trauma. However, it exposes the patient for more radiation, and it's expensive.
Anything else?
So mainly the disadvantage, it's being expensive radiology and exposing the patient for radiology for high radiation. And the advantage,
And
it's
might be time consuming. It might be time consuming in life critical scenario, but usually in non-critical scenario, it's not life time consuming. When would you prefer CT hip in trauma patients?
so an immediate or early CT within 1 hour are required if the patient glaucoma scale is less than 13, I guess, initially, or have been dropped to 2 grades after 2 hours. Okay, or if the patient has history of vomiting or seizures, and if in case of any suspected vault skull fracture or base skull fractures with signs such as raccoon eyes or battle sign or otorrhea or rhinorrhea. Okay, that's indication for immediate CT.
Yeah, that's right. Yeah, okay. So you said this is the half of the answer, as you can see, right? So you want to divide it. I'm going to do CT within 1 hour, not necessarily immediate, and within 8 hours. Okay, within 1 hour, GCS at presentation is 13, or less than 15 2 hours later, or fracture, or post-traumatic seizure, or neurological deficit, or more than one episode of vomiting. You want to say very clearly. You don't have to go into the specifics, right?
Okay.
So you want to say initial GCS is 13, or after 2 hours is still less than 15. Skull fracture, traumatic seizure, neurological deficit, and vomiting. All right. On the other side, I'm going to do a CT scan within 8 hours, age more than 65 or less than 2, bleeding or clotting disorder, dangerous mechanism, or more than 30 minutes retrograde amnesia. What is the Cushing reflex?
So Cushing reflex, it's a neurological reflex mainly by the autonomic nervous system, vagal and sympathetic, by Cushing triad, bradycardia, hypertension, and regular breathing.
So you wanna say Cushing reflex. It's a physiological nervous system response, which is mixed vagal and sympathetic response, or parasympathetic and sympathetic response, and it's a triad of hypertension, bradycardia, or regular breathing. What is lucid interval?
It's a brief period of improvement of the level of consciousness after concussion, and followed by rapid deterioration due to hematoma collection.
Okay, so you wanna polish up this definition. So you wanna say it's a transient or temporary improvement in extradural hematoma patient condition, followed by significant deterioration and drop in GCS. Okay, I think it's much better to say it this way. So transient improvement in neurological condition in patients with extradural hematoma. Okay, what's the management for this scan or this patient?
So this patient has a severe trauma. He is critical, so I have to follow the ATLA protocols. Initially stabilizing the patient by the
This
ABCD
is an
approach.
isolated head injury.
So not these patients. Okay. Yeah, but serious injury, I guess.
Yes. But it's isolated head injury. Let's say this is just an extradural hematoma. The patient had, significant head injury, and it's
Okay.
yeah. What are we gonna do?
So this patient need his condition need to be discussed with multidisciplinary team and to be transferred to the high dependency unit.
So the
And
MDT happens the trauma MDT happens every Tuesday in the afternoon, and today is Wednesday. What are you gonna do? Are you gonna wait for a week?
no, we have this patient will definitely will need surgical intervention by evacuation of the hematoma or craniotomy. So I
Yeah,
have to refer him to neurosurgery.
yeah. But what kind of surgical intervention?
Decompressive craniotomy or per horse.
You're gonna do bare holes to this? It's an acute hematoma.
Yes.
No, you're not gonna do bare holes. So it's very important to give a good answer. All right. You started very good by saying
Mm-hmm.
I'm gonna do an ATLS management. Okay. And then you
Mm-hmm.
added a good thing as well and said I'm gonna do surgery for this patient. They're both good
Mm-hmm.
answers, but you want to make it a little bit comprehensive. So you want to start by saying, like exactly like I said, this patient had a major head injury and has significant hematoma, causing significant midline shift, and he's clinically deteriorating. GCS is currently 8. So he will require some sort of intervention or surgical intervention. Okay,
Mm-hmm.
and after we finish all of that, however, we need to deliver this plan safely. So I'd like to follow the ATLS protocol, make sure that this
Mm-hmm.
airway is patent and secure, and it's very likely that he requires intubation, either prior to the operation or in the anesthetic room during the operation. Okay, so after securing the airway, I'll get some bloods, including the preoperative blood. This includes Gruben screen and cross-matching. I would also look for other injuries, but this is life-threatening injury, and the patient will require operation straight away. What kind of operation do you offer? So what you want to do, you want to evacuate this hematoma. The patient is very young, so you don't want to do decompressive. You just want to evacuate the hematoma, right? So you're going to
Mm-hmm.
remove part of the bone. So it's called decompressive craniotomy, all right? Decompressive craniotomy, not craniectomy,
Mm-hmm.
and evacuation of the hematoma. Okay.
Okay.
You can
Okay.
add to that things like management, right? Or like logistical management. You can add to that, I would like to book this patient into theater, speak with the theater coordinator, speak with the neurosurgery team, speak with the anesthetics, speak with the ITU team, and update my seniors.
Mm-hmm.
Okay. And also something really important to consider in every scenario, that you're doing, you need to change who you are. And by this, I mean, in this scenario, it's a neurosurgical scenario. You are the neurosurgery SHO.
Mm-hmm.
In the liver laceration scenario, you're the trauma SHO. You're the general surgery SHO. You need to deal with that as if you are the junior resident on call on this day in this specialty. Because people tend to forget that as a junior doctor, you need to be like generalist, right? You're managing basically everything. So don't say, I'll speak with the neurosurgery team. Well, you're part of the neurosurgery team. You're the junior SHO, right? Junior neurosurgery SHO. What are you going to do? I'm going to speak with the neurosurgery on-call registrar. That's more specific. I'm going to escalate to my seniors, including neurosurgery registrar and neurosurgery consultant. Because people tend, when it's a general surgery scenario, let's say, what's your specialty, Waleed?
General surgery.
Yeah, if it's a general surgery scenario, I'm sure you're going to say, I'm going to speak with my seniors,
Yeah.
because you tend to forget that, you ignore the fact that you're just covering general surgery and you ignore any other specialty as well. So in every scenario, you need to change the way you speak. Okay. What's the indication in intubation and trauma patients?
Glasgow scale less than 8.
Yeah.
Okay. Or if it drop more than 2 points later on.
Yeah.
If the patient has uh, risk for compromising his airway or seizures or increased intracranial pressure. If he has any maxillofacial injury.
Okay. Yeah, that's all correct. But you need to have some sort of a system, right? You need to have a system in the way you answer it. Okay. So bottom line, if the patient is unable to maintain their airway for any reason, you need to intubate. Okay. If the patient is desaturating for any other reason, you need to intubate. Okay. If you need to protect this patient, you will protect them, you need to intubate. These are the three common things. Okay. So who are the patients who are unable to protect their airway? So these include patients with GCS less than 8, or they have significant destruction or significant injury to the face, mandibular fracture, tongue swelling, anaphylaxis with significant swelling into the pharynx and the larynx as well. Risk of ICP and agitation. So this includes patients with traumatic brain injury who you want to protect them. So you want to sedate them. Or those patients who are having seizure with continuous frequent, contraction of all the muscles of their body, including laryngeal muscles. So their respiration can be affected. So you need to sedate them and protect them by intubating them. Okay? Or they have bleeding or fractured mandible, etc., like we said. So 3 common reasons: patient with unable to protect their airway for any reason, whether it's a low GCS or trauma, or patient that you need to protect them, those who have high ICP or have seizure. All right, or patient who are their ventilation is affected. All right. So let's say this patient's with significant heart failure, significant pulmonary edema, or they have any problem with the absorption of oxygen. Okay. All right. Overall, well done. You need to focus on a few things and try to be very specific. The CT presentation was really good. Advantage and disadvantage, you've answered it very well. When to consider a CT scan, you need to be specific and quick. You say I'm going to do it in 1 hour or 8 hours. 1 hour, this and this and this. 8 hours, age more than 65, bleeding disorder, and etc. for the more than 8 hours. Cushing reflex, you need to polish out the definition and mention the triad. It's a combination of sympathetic and parasympathetic reflex, and it's a triad of hypertension and irregular breathing, bradycardia, and lucid interval. And instead of making up a definition, it's a transient improvement in the patient GCS in the patient with extradural hematoma neurological condition. The management, again, there are many ways to say it. The management is the star question here. You need to answer very well. You need to answer like, exactly, you're a general surgeon. You need to answer it as if I'm asking you, you have a patient with bowel obstruction. How are you going to manage this? I'm sure you're going to give me a very good answer. You're going to say you want to resuscitate this patient, and then you want to prepare them for an operation straight away because I'm very worried about them. Otherwise, they can go into bowel perforation, and then they go into peritonitis. So you're going to give me a very good answer. So here as well, you want to, 1, recognize the issue. So what's the issue here? The issue that I'm having a patient with significant extradural hematoma, significant traumatic brain injury, and they are dropping their GCS. So this is very serious. If I don't do anything, they will die. All right. So this is how you recognize the issue. After you recognize the issue, you say, how would you manage it? The management here, I'd like to, first of all, follow the ATLS protocol, make sure that the airway is protected, and prepare them for surgery by taking Gruber screen. And they will need to be operated by doing a decompressive craniotomy and evacuation of the hematoma after speaking with general surgery. There are lots of logistics to arrange around this. First of all, I'll make them ready for surgery, speak with the theater coordinator, speak with the anesthetics, speak with the neurosurgeons, and consent the patient and they speak with their family. All right?
Right.
Okay. Well done. So lots of questions here, not necessarily needed, but we're going to speak through them anyway. What's the path of physiology of an increased ICP?
Yes, because the skull is a fixed box, and it contain three contents such as brain, blood, blood, and CSF. So any increase in one of these components can be compensated by other two components, but there is a point which this compensation will not be compensated. So it will lead to increased intracranial pressure in this situation.
Yeah. I mean, you do understand what you're talking about, but probably if you're speaking in your own language, not English, you will explain it way better than this, right? Do you agree?
Can you, sorry, I didn't understand.
So what I'm saying is, you do understand what you're talking about,
Yes.
but probably if you were speaking in your own language, you will give me a good answer or a better answer.
Yes.
Do you agree? Yeah. So I feel like you're struggling to get the words out. So just try to be.
Yes. What should I do then?
And what is that? The skull is a closed box. So just try to make it like as if you're making a few statements. The few statements are, first of all, the skull is a closed box, and it contains lots of structure. And this includes the parenchyma, the blood vessels, the nerves, all right? And obviously the brainstem and the cerebellum as well, all right? So the brain, brainstem and cerebellum, blood vessels, CSF, and the nerves as well. Nerves are quite insignificant, but the other structures are the main component. Any increase in the volume of any of these structures will affect the others, or will result in compensatory decrease in the other two. All right. So one ICP reaches around 25 millimeter mercury. There is a small increase in any small increase in the blood volume will lead to significant increase in the ICP. So if you make it as statements, like a few statements, all right? So one, the skull is a closed box. Two, it has multiple structures, brain, blood vessels, and CSF. Three, any increase in the volume in one of those components will affect the other two. Four, if you have an increase after increase of the ICP to 25 millimeter mercury, any further increase in these components will result into significant increase in the ICP.
Yes.
What's the conditions where you would like to monitor the ICP?
Yes, intracranial hemorrhage, subarachnoid hemorrhage, hepatoencephalopathy.
Spontaneous or traumatic subarachnoid hemorrhage?
Sorry?
Do you monitor ICP in a spontaneous or traumatic subarachnoid hemorrhage?
Traumatic.
Okay.
I mean, in case of traumatic head injury, intracranial hemorrhage, or extradural, subdural, or subarachnoid hemorrhage, which is spontaneous, not traumatic. Subarachnoid hemorrhage.
Okay. I disagree with most of this, unfortunately. I do disagree with most of that, okay? So you want to say you monitor the ICP most of the times post-operatively following evacuation of a supratentorial hematoma, all right? For those patients with low GCS or abnormal pupils or have midline shift. So any patient that you look at their scan and you find it very crowded, there is effacement of the sulci and the basal cisterns are not patent, so you need to monitor their ICP. Otherwise, it might go very high, and you're unable to check how their brain is affected by the high ICP. And also, you need to monitor it in patients who are in induced coma following traumatic brain injury. So when you have a patient with traumatic brain injury that's quite significant, that's usually not surgical, and they go into ITU, you need to neuroprotect them. Neuroprotection means you're trying to sedate them. You're trying to avoid them, to avoid making them do anything that can increase their intracranial pressure. So when you cough, when you just cough, your intracranial pressure increase. When you strain, if you're on a toilet and trying to do Valsalva, right? Valsalva increase your intracranial pressure. If you have a seizure, that increases your intracranial pressure, right? So if you have a patient with a subdural hematoma, acute subdural hematoma, that is very small, and this is not surgical, it's less than less than 1 centimeter in diameter, all right? And you go into ITU. If they cough, their intracranial pressure will further increase. The bleeding might actually increase, etc. Right? So what you want to do, you want to neuroprotect them. You want to keep them in ITU, intubate them, sedate them, prevent seizure, prevent cough, prevent Valsalva, prevent everything. Insert a catheter in, urinary catheter, manage their bowel for a few days until their ICP is well managed and the hematoma is absorbed or reduced in size. Okay, so you want to do ICP monitoring in patients who are comatose, who have whether traumatic subarachnoid hemorrhage or petechiae or contusion or bifrontal contusion or maybe subdural hematoma, etc., etc. Sometimes in normal pressure hydrocephalus patients, you do monitor the ICP to diagnose the normal pressure hydrocephalus as well. Does that make sense?
Thank you.
Yeah?
Yeah, thank you.
What is the normal value for ICP?
Yes, we have in spine and standing position. In spine position, it's between 5 to 15 millimeter mercury, and in standing position, it's between 0 to 10 millimeter mercury.
Okay, and what are the ways to measure the ICP?
We have according to the location and technology. And location like extradural, subdural, in ventricular, into transcranial Doppler and subarachnoid. And technology like external strain gauge also, and catheter tip, and fiber optic. I really just memorize it. I don't know what they are, most of them.
Okay.
Yes.
That's fine. Don't worry. So the answer needs to be a little bit better as well. So the ways to measure, do it in multiple ways, all right? So you can do it intraventricular catheter, an intraparenchymal probe, and also lumbar CSF pressure.
Yes.
Those are the main ways that you want to do, okay? Otherwise, the other methods, they're not usually used. They're not usually very common. You can also say you can do it invasive and non-invasive, all right? But usually the ICP monitoring is almost always invasive. So you want to do intraparenchymal probe or intraventricular catheter or a lumbar catheter as well. All right? Okay. What are the dangers of doing lumbar puncture in patient with increased ICP?
In case of in a patient with increased intracranial pressure, there is a risk of herniation and coning, which lead to brainstem death, cell death.
Yeah.
Yes.
Okay. Yeah. Risk of herniation. What is the clinical picture of increased ICP?
Yes, we have general clinical pictures such as headache, nausea, vomiting, papilledemia. Pupil may be dilated by oculomotor nerve palsy or lateral gaze loss or defect by abducens nerve palsy. And we have cushion stride, which include hypertension, bradycardia, and irregular respiration.
Okay, sounds really good. And what's the management of raised ICP?
Yes, we should do.
So, I mean, it's the same concepts that we talked about. You talked about.
Yes, increase. We should do either increase venous drainage or decrease blood volume. Yes.
Yeah, I mean, you need to, well, that's fine. So let me just say the answer. So first of all, it's the same concepts that we talked about. You talked about the Monroe-Kelly doctrine, all right? So what you want to do is you want to start by the medical management of ICP. What's the medical management? Your patient need to be set up a little bit, up to 30 degrees. Their neck need to be in neutral position.
Yes.
So you want to improve their venous drainage. Okay? You want to prevent anything that will increase the blood pressure, including seizure, including cough, including a strain. And this you're going to do by sedating your patient. All right?
Yes.
So you want to sedate your patient as well. You want to reduce their metabolic rate. You want to make sure that their PCO2 is in the low normal side, not more than 4, right? 4.5 maximum. So you want to make it on the lower end. Okay? And then this is the medical management. And then the surgical management. You want to drain some CSF. So you want to put an EVD in. And you can also do decompressive operation, decompressive craniectomy operation. So this is the medical management and the surgical management.
Yes.
All right? Okay. So Reem. Subdural hematoma. You have an 80-year-old female patient who had mechanical fall 2 weeks ago and presented 2 weeks later to A&E with reduced consciousness, and she opens her eyes to pain and makes incomprehensible sound and withdraw to painful stimuli. What's this patient's GCS?
So this patient has 2 for the eyes, 2 for the verbal, and 4 for the motor.
What's the patient's GCS?
So 8.
Okay, so the patient's GCS is 8. What do you want to do?
So since the patient has a GCS of 8, as in management,
I don't know. What do you want to do?
so I'm going to start with ABCD. So make sure the airway is patent. We're going to intubate this patient since the GCS is 8 and the patient has reduced consciousness. We're going to make sure check the breathing. So for the breathing, I'll check the saturation, check the percussion, auscultation, and all that. And then we move on to circulation, where we're going to check the heart rate, the blood pressure, make sure the patient is stable. We're going to insert 2 IV wide bore cannulas, extract blood, give IV fluids, and if the patient has any signs of bleeding, we can also do a cross match and possible transfusion. And then we're going to look for any disabilities. We're going to check the blood glucose as well. We're going to what else?
Hey, I think, yeah, you've done pretty well. You've done all of that and everything is normal. Apart from the blood clotting, which is a little bit deranged. Her INR is 2.5. But everything else is normal. What do you want to do now?
So if INR is 2.5, we would give I'm not sure.
Okay, so are you going to leave your patient to die?
No, obviously not.
Are you going to diagnose this patient? We're interested in diagnosing them. You've done everything, but you haven't diagnosed your patient. Do you have a diagnosis?
They could have a hematoma since she's an old patient. She had a fall, and she's been having progressive reduced consciousness like a week later on. So we're going to do imagings So we'll do a CT brain, non-contrast.
Okay.
And
now we're talking. So you've done everything, like I said, everything is normal, and you intubated your patient, you've done everything you can, and her INR is 2.5. You've done a CT scan, and this is the CT. Do you want to tell me what's the abnormality with this CT scan?
So this is an axial CT scan of the brain. We have a right-sided hypodense area that's lens-shaped with midline shift and loss of
Is this a lens shape?
Sorry?
Is this a lens shaped?
No, this is a convex shape. This is a. I lost the word.
Yeah, you lost the word.
Yes.
I would say banana shape and lemon shape. That's something that I will never forget because I love banana and love lemons, right? So
Can
banana
we
shape.
call it a banana shape?
This is banana shape, right?
Okay.
And the extradural is lemon shaped. Okay, you want to go for lens? Yeah, that's fine. Lens shape is extradural and crescentic in shape, like a crescent, right? Crescentic in shape is the subdural hematoma. But you need to be, Reem, you need to be a little bit more quick than that, right? You need to tell me what's the diagnosis here.
So it's a subdural hematoma.
What's the subdural? Is it acute subdural hematoma? It's subacute? Is it chronic?
It's an acute subdural hematoma.
It is not an acute subdural hematoma.
It's chronic.
Okay, so thank you for your participation, but let's make Reem answer the question, please.
Okay, question.
Thank you. So Reem, why did you say it's acute? Okay, so it's okay. After this session, what I would like you to do, search on the internet, Wikipedia, and just write aging of the blood on a CT scan. All right? It will give you really cool images on how it looks like on the scans. Okay, but just make sure you write that after our session. Don't forget. So acute blood looks exactly like bone. It's very hyper dense. Looks like this one, like the fox here. Looks like this area. This is acute blood. Look at this one. It's a little bit grayish. It looks like the brain, right? So this is subacute blood. This is more than 3 days old. And this is black. It's very close to the CSF. And that's chronic blood. Okay? So this is, you can say that this is acute and chronic or subacute and chronic subdural hematoma. Or simply, this is a chronic subdural hematoma. All right, so let's not get carried away here, okay? Let's just give the answer to the examiner. We don't want to talk too much in the exam, all right? So you want to say, this is an axial CT scan. The most obvious finding is right-sided chronic subdural hematoma, okay? So you want to start by saying this, and then you can go further and explain your findings. You can say it's a right-sided, crescentic shape, hypodense, measuring 1 centimeter, causing mass effect, and midline shift, effacement of sulci, compression in the ventricle. Very likely this is chronic subdural hematoma, and it's quite significant. Okay?
Okay.
Well done. So now you have a diagnosis. You've done all your bloods and workup, and you've stabilized your patient. What do you want to do now?
So we start with the medical management of the CT, of the hematoma.
Yeah. What are you going to do with the medical management?
So we start off with, as like the patient is stable right now, right? We're done with all the ABCs.
Intubated, she has all the bloods, she's being resuscitated, and you have her blood results as well. What do you want to do?
So make sure the patient has everything, like all these things, and then I think for subdural hematoma, it's just urgent surgical treatment. Actually,
You think? Or are you sure?
No, I am sure. It is.
Okay.
We have to urgently evacuate the hematoma.
How are you going to evacuate that?
So we have 2 ways: either burr-hole evacuation or mini craniotomy.
Well done. This is what I wanted to hear from the very beginning, right? So you want to say it very confidently. The patient is clinically unwell. Her GCS is 8, and she was very confused before, and she had trauma. The scan has confirmed a significant subdural hematoma with significant mass effect. This patient is operable. She would require an urgent operation in the form of bare hole evacuation or mini craniotomy. Right? This is how you answer it very confidently. Okay. So I think we've pretty much covered the whole scenario. But there is one thing that you forgot to say in the management. Okay, I'm going to tell it to you differently. So you took this patient to theater for an operation. As soon as you're touching the skin, she's bleeding to death. She's bleeding a lot. And you start doing the bare hole evacuation, and the patient has lost significant amount of blood into her brain as well. So she's turned out to be an acute subdural hematoma. What have you done wrong?
Coagulation cascade, or
What's a coagulation cascade? What is that?
I mean like coagulation profile.
2.5, and you haven't reversed that. You didn't look into this.
Yes.
You just took her to theater, so that's wrong. All right. So your preoperative management was incomplete. So you want to say, I want to reverse that. How are we going to reverse the INR of 2.5? First of all, you want to find the reason. What do you think might be the reason?
Patients might be on medications, might have bleeding disorders.
What kind of medication she can be on?
Sorry?
What kind of medication she can be on? Warfarin. You want to say warfarin, right? So she might be in warfarin. So you would like to take further history, collateral history from the family. You speak with the family. This patient has atrial fibrillation, and she's been taking warfarin for the last 2 years. Yeah?
Mm-hmm.
Reverse that. How are you going to reverse warfarin?
Vitamin K or platelets, FFP.
Anything else? Human thrombin complex. That's the main answer. And this is what you're going to give in this patient. You're not going to give her vitamin K because it's not going to do anything. It takes 6 hours to work, and you don't have 6 hours. You can give her fresh frozen plasma during the operation, and human prothrombin complex is the main thing that I would like to give before the operation. Okay? All right. So overall, I think performance needs to improve. Okay? You need to be specific, and the main advice for you, you require lots of prompting. You require me to prompt you or poke you to give me an answer. All right? So you want to give me the answer straight away without, fiddling around a lot.
Okay.
All right, but well done overall. All right, I'm so sorry